gynecologists who really face challenges in implementing these guidelines. So we start with Dr. Chitra. Dr. Chitra, I would like to ask you, in the light of these guidelines on preventing unwarranted hysterectomies, what are your insights faced by healthcare professionals, and what measures can be implemented to enhance the monitoring and evaluation of these cases of hysterectomy?
See, the guidelines are very, very well formulated and everything about hysterectomies less than 40 years of age. But as obstetricians and gynecologists, the problems we face are entirely different, because there is a lot, as in the previous discussion it was said, there is a social implication also, which we face to a large extent. One major implication is that hysterectomies are found more in the villages, in the poorer country, in the poorer states, where people are actually farmhands and people are working for their daily earning. And if they have problems, as it was mentioned earlier, they report to a doctor very late, because women's problems they consult amongst themselves. And a lot of evidence or opinion is taken from the nearby people. They'll say, हाँ जी, menses में ज़्यादा होते ही हैं bleeding. So they come to a doctor very late. That is the major issue. And by the time, as it was already said earlier, they're grossly anemic. So when it comes to treating their anemia and telling them, counseling them about a long-term treatment, they are more than ready. I mean, they've already made up their mind, ab ye uterus nikal do. Because as was said earlier, they get married by the age of 16, 18. They have completed their family in their early 20s. By 25, 26, they've completed their family, and they start all these problems by the time they are about 28, 29. And they've been told that the work of the uterus is only producing babies. Nobody has been counseled regarding the other problems which happen when the uterus is removed. So this is one major problem. Secondly is that in most of the primary health centers and in the smaller places, it's the surgeons who are doing the hysterectomy rather than the gynecologists themselves. It's the general practitioners calling surgeons to do hysterectomies, and they don't understand the significance of the ovaries. So a lot of unnecessary ovaries are also removed. So these are two major problems which are faced we have been working in metros. We have studied in Lady Harding, and we were facing less of these problems, but when you look at Bihar, which has got the highest numbers, these are the major problems which are facing.
So what would you say, how can interdisciplinary collaboration, coming forward from your statement, collaboration between the gynecologists, the healthcare workers, the general practitioners, how can that be implemented so that we educate even the general practitioners regarding the reason for hysterectomies or not doing a hysterectomy, and how can we carry this forward?
As was discussed in the previous panel, there is a lot of requirement for the government to work a bit more about educating even the general practitioners of the poorer states, because they really don't know much about what are the alternative treatments, and making things available over there. Like the newer things, what we do a hysteroscopic polypectomy and the uterus is saved. But these facilities are not available. And government hospitals are grossly overcrowded, so people don't want to go there. They are daily wagers. They don't want to go to a government hospital. They'd rather go to a private center and get it done. And they feel that getting the uterus out is better. So a lot of social awareness is required, and probably, going personally to the thing, which is the government has to do something about it. Another one thing is probably, all over the ASHA workers have been in contact with the villagers, with the average this thing. And they've all been concentrating on obstetrics, part of it. If we can teach them about gynecology also, that would be a major role which the government can play.
So basically, we need to sort of emphasize on educating our public and educating our health workers regarding this. So, and Finally, considering the regional variations in healthcare practices, what strategies can be employed to ensure uniform adherence to such guidelines? I mean, we've said one state has a higher incidence of hysterectomies, another state doesn't. So can we do something about it as healthcare professionals?
As healthcare professionals, we can only conduct symposium, conduct educational classes for all these states, the particular states which are this thing. But most of the time, these particular states have a lower level of education. So if the primary education is better for girls, for women, that would be the major thing which the government can involve.
Thank you, Dr. Chitra. Dr. Ragini, what strategies can prove effective in overcoming challenges relating to this implementation? And what is your take on public awareness campaigns and the digital media in promoting awareness about menstrual health and heavy menstrual bleeding and the need for not doing hysterectomies?
So thank you, Dr. Guleria, for this question, and I thank Dr. Ms. Himani to invite me here. There are 4 things. Number 1, whatever I heard in the previous panel, here we are sitting to give a solution to a problem which is causing a major ill effect to the health of the woman. Woman is a very important part of a family. But is it true? What is the position of a woman in the society? I'm not talking of the women who are sitting here. I'm talking of the women who are sitting in the villages, in a families where semi-education is there. There are big family who takes the decision on behalf of that woman. So I think the end users has to be empowered with the knowledge. End users has to be given that responsibility that they can take decision for themselves. Saying that doctor does that, this blame game is not going to solve this problem. As that gentleman has said very clearly, there's only 2 things. Number 1, society has to take a step towards to solve this problem. One hand cannot do anything unless we can take a participation from the public. It's just like imposing something. And second thing, what Dr. Chitra has said, that is very important. We have to think that India is a heterogeneous country, very big country, economically, education-wise, religion-wise, and then overall culturally, it is a heterogeneous country. We cannot put a bland thing everywhere. We have to see the ground realities. I am a person who will do hysterectomy as a last choice. But what type of people we are catering? My patient is ready to come back to me, want to follow. Think of a woman from a village with much and much difficulty. When she reaches to a hospital, she is already anemic. And she cannot come every time. She cannot go follow up. So we have to address grassroots and give them those facility to the grassroots women. And only then we can save the unnecessary hysterectomy. The whole hurrah has started from those women whose hysterectomy was done in a state. They are the sugarcane workers. Have ever you thought why have gone? Because their wage is linked. The husband and wife wages are linked. If woman is not working, husband is not getting the wages. Why? This is such a, if you think of it, it is a gross injustice. So number 1 thing, Dr. Rakhi, if you ask me, the education of a woman, empowerment of the woman with education, financial independence, social independence will play the biggest role. Number 2, the government. Don't blame the private person at all. I'm totally against it. Government is there to see the affordable health for the person. Why those women should not get those help at the village side? And they should be taught that you have to go for a regular checkup. Because it is not only at that time preventing a hysterectomy. Maybe she is developing a cancer also. If she will not go for a regular checkup, She's not go for a regular pap smear. She will not go for a regular ultrasound, and followed by a doctor very closely till the age of 50, 55 when she attain a menstruation. And meantime, if she will develop something, this is again on the head of the doctor. So when we talk about the hysterectomy, it is just not a removal of uterus. Believe me, 90% of the gynecologists, I'm saying this word gynecologist, most of us are women. We don't want to remove any uterus. We want to give the conservative treatment, but think the cost of the conservative treatment. I'll just say one line. Again, on record, I'm saying I'm a person who is totally anti-hysterectomy because I respect a woman. Being a woman, uterus is as an important organ as your any other organ. We cannot, it's not a vessel to produce a baby. But a real example I'm giving you. A lady of 36 years who has a 20-year child and the 16-year of a child is bleeding and bleeding and bleeding. She comes in my OPD and said, "Doctor, remove my uterus. I don't want, I have a two baby." In our country, they are specifically in the village side, they are not going to divorce the husband and going to have another husband. So the husband will also say, "We don't want, remove it." She is not able to do the day-to-day work. And I'm running around with her everywhere. Now I said, "No, I will not do a hysterectomy. I will putting you on a tablet or now we have a very wonderful system that is Mirena. We put with that. And not it is costing something very great, but this education of Mirena or levonorgestrel ICT is there in the population. No, they are so scared of the copper T, they are not going to put it. If I put them on the tablets, those tablets are so costly. A tablet will come around 20 to 25 rupees per tablet. Think if she is going to take it 5 years, how much money? From where it will come? So there are so many things before we are thinking the unnecessary hysterectomy. As that gentleman has really pointed out, we have to think of how to provide the medical management, which is the need of our, and educate the woman and put it in the even medical curriculum. That woman, that the girl, the doctor which is coming out of the education, she knows that she has to do a medical management. And third point, this is very important. Today, not only gynecologists, everyone, even now the non-MBBS doctors are also doing the hysterectomy. So who is that wrong?
Yes, ma'am. Now, coming forward on this, I would also, since we are now in the phase of digital media and everything, and we can really enhance the knowledge of people through our digital awareness campaigns and things. So what is your take on this? Should we really propagate this through our digital media, since everybody has a mobile phone and everybody has the net?
Dr. Rakhi, you have touched my real nerve. I'm a person who is too much for the digital media public education. I'm heading this social education program of the Haryana IMA also. When I'm sorry to say, when I put my whole heart in this education, this digital education, hardly there's a person who is going to listen it. I go to many, many women institutions. I tell my patient, you arrange in your kitty and give me time for 5 minutes just to educate you on any point. But not a more of the people are interested. Yes, you can do this public education by the digital media, arranging a group of the women in the villages where there's a Asha Bai or somebody was there and there's a screen, and maybe sitting in Delhi you are speaking. That can be done. But if you're thinking you just say that people are open on their mobile, I'm sorry to say I have done 35 public forums, but hardly I have got anyone to listen it.
Okay, so that is again one thing which we should also push the government for, to use their digital media to propagate our views. Dr. Rakhi, coming forward from this. Now, what role do patient advocacy groups and community engagement play in creating awareness about the potential risks of premature hysterectomies? And how can we amplify these efforts? Do you want me to repeat? Yeah. Okay. What role do patient advocacy groups and community engagement play in creating a public awareness about the potential risks of premature hysterectomies? And how can we sort of enhance these medical campaigns or tailor them to reach a broader audience?
Yeah. Thank you, Dr. Raka. Basically, the public advocacy is the mainstay for this whole thing. I would like to start by telling it is that nobody wants a surgery to be done. Anybody sitting in the hall or anybody sitting over there, who would want a surgery to be done? Nobody. It is nobody's business that we go directly and tell that we want a surgery. It is why? Because it has been asked by the public. The doctor will not go to the patient that you come, I'll do a hysterectomy. No. The demand is created, that's why the supply is there. Right? And the second point is education of the public has to be done, which is very important. That will come where the public is going to recognize it from. Every village has somebody to look after or look up upon. That is the Gram Panchayat or the heading person, or on the mass media platform, it is like, I would like to give the example of the oral polio. It was done because of the advocacy. And this is how we do it. And if it starts coming before if you start putting it on the TV, if you start putting it everywhere around on the radios, that will work. The awareness why it has not to be removed has to be taught to them. And either you do, the second part is, either we start educating all of them post-delivery that LNG IUD can be placed immediately postpartum, right? That has to be educated to them during the delivery, during the pregnancy part itself, antenatally, and so that the bleeding is less, then all the other problems would definitely sort to. But coming down to the cost, that cost factor also can be taken care of. It's just the awareness what has to be taught to them. That, see, the cost would be very less when compared to vis-a-vis how much you're going to spend for the surgery and how much you're going to spend later on suffering for the anemia. So the anemia is also taken care of, the surgery is taken care of. That has to come right during the pregnancy counseling itself. So when the bleeding is not heavy, the patient is happy enough, definitely the surgery point doesn't comes forward. And the third thing is digital media definitely plays a major role. That is, if the stars or if the influential persons come forward and starts propagating that every nook and corner, if it is placed that yes, preserve the uterus is important, and why it is important. Why is the main thing which has to be educated. Why it's not the organ which just gives babies. There are more functions to it. The hormones are produced. The hormones are very important. If those hormones are withdrawn from the body, if you're removing the uterus at an early stage, at say about 35 years, when the menopause is going to occur at around 50 years or 45 years, at the max also. So if you are removing all the hormones, what it is going to happen, how it is going to affect that female, it is definitely going to cause cardiac failures, cardiovascular problems, it is going to cause a bone health issues, osteoporosis would come in, and there would be fractures which would be, if the female is going to have fractures way back, I say about at 70 years of age, 65, 70 years of age, that fractures would go down to the age of 45, 40 years of age, or 50 years if the uterus is removed, say about 25, 30 years of age, 35 years. So that the patient starts looking older.
The patient will have the sexual life also being compromised. There would be decreased lubrications. There would be other more problems like hot flushes coming down. There would be urinary problems which would be starting down because the bladder is very close. And there would be the bowel and the bladder, both would be hampered. Every problem is starting over there. Sleep would be hampered. There would be depression. So if we are highlighting all these important points, that would definitely create an awareness. And one more thing, it is not the female who is taking the decisions in India. It is a male-dominated society, and the males are taking the decision. And the education has to come from the head of the family, or the males also are equally partnered in it, and they have to be educated that these are the problems which would be coming down. So we have to take care of our females in the family, get them to the health checkups, which is very important, and not sit on it that is just she's bleeding normally, and that is normal that to have a heavy menstrual bleeding. And they don't come down for the follow-up checkups because the males are busy working and then the females are in the house. They have to take a leave to get the wife checked up. That is also another issue. That's why the females are lacking. And they come and tell it's roj ki nautanki, please get the uterus out. It is not the demand which is created by the females. It's a demand from the family. It's a demand by the person who's taking care of that female. That has to be checked. And awareness has to be coming in all the social media platforms, like in the marriages or any other gatherings. There should be a mandate that a small video has to be played. It's okay. 100 बंदे होंगे, 100 के 100 नहीं देखेंगे, पर 10 तो देखेंगे, 15 देखेंगे. Awareness would start right from the beginning. 10 बार hamper करोगे, तो एक बार तो याद होगा ही.
Thank you, Dr. Rakhi. I think you've covered a really broad aspect of how we can educate our males to let the women take the decision in their lives. I would just like to add, maybe this education awareness should start from schools as well. Yeah. When we have health education programs in school, we should have more education and information regarding menstruation and what classifies as heavy bleeding and what is normal bleeding.
That has been there in place in most of the schools, and that has been, I was part to that adolescent health and family welfare education programs which are been by the government of ministry which was there. I was part of that education programs which were done all over India, and it was told in that adolescent clinics which have been established. Not definitely the private schools are doing that menstrual hygiene program, and then this is a part of the government programs, the adolescent clinics which have been put up in place, and there they have been teaching all the schools and the nearby places also how the menstrual program has to run, and how much is okay and how much is more to it, and where to put a stop and where to go to the doctor and take a help for it.
Thank you. Question from you. How can correct data and numbers be ensured when we're doing an audit of surgical interventions like hysterectomies? So how do we maintain our data and how do we do an audit?
The data and the audit, definitely it is there in place by the government itself. All the private hospitals are definitely asked to send all the data of the hysterectomies. Let it be above 50, let it be below 50, or let it be below 40. Let it be the cesarean hysterectomies, whatever it is. And apart from that data, it is a mandatory in that form itself that the cause of the hysterectomy has to be mentioned. Apart from the cause, what medical treatment she has received and how long is the medical treatment and what all are the parts of the medical treatment she has received to avoid hysterectomy. to preserve the uterus. That is also part of it. And there we come to know where we are standing. And it is, the onus is on all of us that we need to report it. Apart from the private partnership, the public, that is the governments, are also supposed to report it, and that is how we do it. And it was very nicely told by Dr. Madan Mohan that it is the data which comes little late, and it has been audited late, because of which we get up from the sleep little late, where all other prime areas where the requirement is there. If the data has been nowadays, everything is on the computers, and we are digitally more savvy nowadays, and at the government end also everything has to be uploaded at the digital end, so the things would be coming down to us little early. That is the presumption what we are having it right now.
Thank you. Dr. Manju Puri, ma'am, you are representing Lady Harding, which was established by Lady Harding for the treatment of women of Delhi when they would never be able to go to see a doctor. So I would like to ask you, what institutional strategies have you found effective in capacity building of healthcare professionals, and what recommendations do you have for our policymakers to bridge this gap between formulating guidelines and seeing how they're implemented? And finally, what about our medical curriculum? Are we really not teaching our young doctors about heavy menstrual bleeding, or are we just sweeping it under the carpet?
Right. So I think I'll go one by one. The first part which you have asked me is that what are the institutional strategies we have in reducing hysterectomies? Am I right? Yeah. So basically, we have the subject of hysterectomies and also the related indications. They are there in our curriculum, but whether we are actually, putting in so much of emphasis on the, conservative procedures, and are we giving the right message to our youngsters? That is a bit of a problem. So I think hysterectomy was never considered so much of a problem. Now that it has been flagged, I think it becomes our responsibility that we start looking at and making the foundation of our undergraduates and our postgraduates stronger, and give them, a balanced view, and try and emphasize on all the newer methods. When we were young, we did not have all those methods. So now we need to update. So I think what is lagging is that, whatever changes which happen, the changes in curriculum happen later. And so it takes quite a bit of time. We do not have a well-oiled system that would look at it every 2 years or so, because with the advances going up so fast, I think we need to keep updating our priority areas in the curriculum. And now they have a lot of, we have 1 month of foundation course, wherein they look at ATCOM, that is, their attitude, their communication and ethics. So I think once we emphasize on these points, they would, and we find a great change when the students are coming to us. So they now know that they are not supposed to dictate terms to the patients and tell them, aapke liye ye theek hai. So they give them options, they give them alternatives, they know how to talk to them. And of course, we also focus on ethics. I think these were the things which we were not emphasizing so much, in a more formal manner. They were supposed to look at us and understand and learn. So now with the ethics part, first do no harm. I think that also is a part of it. So all the 4 pillars of medical ethics are taught to them formally, and which they implement while they are being students. And then the communication part, even how to take consent, and you can't just offer one option. You have to tell the disadvantages of that option. You have to tell them alternatives. So all those things, I think we are preparing them better. So that is the part as far as our strategies are concerned. And we need to also focus on more of preventive and promotive, strategies. We were more into therapeutics, treating. So I think now the orientation is changing. We are more talking about, opportunistic screening. As if a patient walks in my OPD, she's a young girl and the BMI is more. So I do look at it and I do gently say that, you need to kind of correct it. So I think as obstetricians and gynecologists, we should now focus. It was initially left to PSM people. But now I think it is important that every specialist, every doctor has a lot of focus on preventive and promotive activities. So this is what I feel. And the second part which you asked me was, could you just repeat the question, please?
What recommendations do you have for bridging the gap between what the policymakers say and how we can implement it?
Excellent. I think it's a very good question. We all know that there are lots of programs which the government has, put forward. We all understand that they are not doing as well as the programs actually are. So there are problems as far as the implementation part is concerned. So we've been working in this particular area under NARCHI. I've been the president for that branch. And what we feel is, this is my personal feeling also, that everything is driven top-bottom. So we get orders from the top, and all the policies are made, and they're just kind of supposed to be percolated down. We do not go into the details of why the programs are not functioning at the ground level. We have to have a bottom-up approach. So that means we need to go to the people, the beneficiaries and the frontline healthcare providers, and whichever level we think should be making a difference, and understand their viewpoint. And whenever you have a very complex problem, which I know that when we look at hysterectomy is the tip of the iceberg. There are a lot of factors which contribute to hysterectomy. So, you can't just solve them in one sweep, that we have started doing an audit and that will solve the problem. Because, different areas will have different problems. So it is only those people who are actually involved in that particular problem can solve that problem. So I guess that we need to go to the grassroots level. And, when you say you have data, so whatever data we have, whether it comes 3 years or whatever, so instead of, wasting our energy all over the country and at all places, I think we need to focus on to get more results and faster results, we need to focus on the areas where actual problem is existing. And we go back there, get a team made of those people who are involved in that problem, and let them deliberate and do a detailed analysis. We call it a fishbone analysis, where you look at people, policy, procedures. So, you look at a very broad, let everyone kind of do a brainstorming and find out what is it they think is causing higher incidence of hysterectomy, and then they themselves will think of the solutions. I can't think of solutions for a rural area. And so they should be suggesting the solutions, and then they should be fixing up their problems one by one. You can't do it with a single sweep. So only that, and that is the way wherein we can have some long-lasting changes. So it has to be done by the people who are involved in that problem, and systematically tackling each of those problems. And that is how the gap between the making of policy and implementation of policy will go.
So it's not a question of one size fits all. One has to tailor make every program to fit every state. So one needs a very good tailor.
And one more thing is there that, we keep passing orders. We keep collecting data, but I don't think so we actually analyze that data effectively. We keep thinking it is not reliable. And then, then we do not monitor. We should have trends. A single point, aaj is month mein ye hua, it has no value. What has been happening? What are the trends? So I think those trends should come. We have digital platforms now. We have AI. So I think we really need to go in a big way to have dynamic dashboards so that the data gets, parked there every month. And with the help of AI, we should know as to which is the focus area, which we can be flagged. And in case we feel that there is a variation in the data, we should be able to identify and go back. So right now, we are just, kind of trying to do everything all around. So my suggestion is that we identify the priority areas and, understand the problem and try solving that, and ultimately it will reduce the incidence of hysterectomies. So that is my understanding of the
Thank you, ma'am. So we have challenges and we have a lot of mountains to climb, but I think with some perseverance and cooperation, we should be able to get there. As Robert Frost said, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. And I hope our deliberation today does reach the ears of the government and they do something positive with our help. Thank you.